Hello, dear medical students. Welcome to my channel. Today's discussion is on platelet in hemostasis. So, this hemostasis and homeostasis you should not confuse. Hemostasis means stopping of bleeding. Homeostasis means body's internal milieu, that is, internal state, is kept in a balance. So, that is the basic difference between these two. So, don't ever confuse it. I'm trying to make this topic as simple as possible for you. Okay. Now, normal platelet count is between 1.5 to 4 lakhs. And thrombocytopenia or thrombocytosis means count that is less than 1.5 is thrombocytopenia, above 4 is thrombocytosis. But clinically significant thrombocytopenia actually means below, say, about 50,000. And clinically significant thrombocytosis is above, say, 7 or 7.5 lakhs. So until then, no adverse event comes. Now, how are platelet formed? It is formed from megakaryocytes. Actually, these are all cut portions of a megakaryocyte. A megakaryocyte actually breaks into so many pieces, and that is platelets. And the thrombopoietin that is produced by liver stimulates platelet production in bone marrow. What happens when there is a vascular injury? The first thing that happens is the primary hemostasis. And in primary hemostasis, the first thing is the vasospasm. When the vessel contracts, the blood flow actually slows down. So much so that the clotting mechanism becomes easier. Because we all know if the blood flow is stalled, the clotting will occur. Now, the second component of primary hemostasis is platelet. And secondary hemostasis is coagulation, which we are not going to discuss in today's discussion. But coagulation also has got activity from platelet. That is the procoagulant activity of platelet. Earlier used to be called as platelet factor 3. But basically, it is the phospholipid, which is the membrane of the platelet. And after the clot has formed, the wound should become smaller, no? So that is by clot retraction, which is also by platelet. Now, coming to the primary hemostasis, it is the process of platelet plug formation. It is a vascular and platelet component, as we have already discussed. The first thing is vasoconstriction. It slows down the blood, that we already said. Second is the platelet adhesion. So when there is an endothelial injury, 1 Willebrand factor, because 1 Willebrand factor is there within the endothelial cell. So when there is an endothelial injury, the 1 Willebrand factor comes out and it sticks to the subendothelial collagen. And once it is there, the GP1B receptor of platelet binds to it. And this binding leads on to the platelet activation. The platelet has got granules, alpha granules, delta or the dense granule, and it releases so many substances like ADP, thromboxane A2, calcium, fibrinogen, 1 Willebrand factor, etc. GB2B3A complex is activated. Activated means that complex, so that receptor was already there. Some conformational change. So now it is ready to bind to 1 Willebrand and the fibrinogen. So there is platelet aggregation or the so-called platelet plug. And the 1 Willebrand factor that was getting attached to the subendothelial collagen, that forms multimers. That means instead of one Willebrand factor, multiple ones comes and becomes a group. And that makes the platelet plug even more larger and even more able to stop the bleeding. But 1 Willebrand factors form the multimers, so many platelets can adhere. And then the platelet releases the materials that I have already discussed, activates the GP2B3A receptor, and thus platelet plug forms. Because GP2B3A will bind to 1 Willebrand factor and fibrinogen, and thus a platelet aggregation forms. We have already said 1 Willebrand factor binds to the exposed subendothelial collagen. GP1B of platelet is lacking. That is, it is not there to bind to the von Willebrand factor, and hence platelet adhesion doesn't happen. Congenitally, it can happen in a condition called Bernard-Soulier syndrome. So here, platelet adhesion is defective. So platelet adhesion can be defective either because the von Willebrand factor is less or functionally abnormal, or the platelet receptor GP1B is abnormal or lacking. Both are possible. But when the defect is due to lack of GP1B receptor in platelet, then it is called Bernard-Soulier. If it is due to defect in von Willebrand factor, then it is called von Willebrand disease. That we will discuss in some other video. In Glanzmann's thrombasthenia, the adhesion is okay, but aggregation is defective. This aggregation defect can occur in other conditions also. For example, uremia is a toxin to this receptor. So uremia can cause this functional defect of platelet. ITP also, the antibody binds to both receptors, but preferentially to this GP2B3A. Now, platelet has got procoagulant activity, the phospholipid or the previously called platelet factor 3, and the clot retractions also. Platelet has got a role that we already said. The fibrin elements are pulled to make the wound smaller, but these are not part of primary hemostasis. These are all part of secondary hemostasis, that is coagulation, which we are not discussing in this video. Time taken for hemostasis is measured in a crude way by bleeding time. Crude way basically because the standardization is not easy, that we will come to. As the platelet gets activated, the procoagulant phospholipids are brought to the surface. So much so, it helps in coagulation cascade. That we will discuss in a separate session. What does bleeding time denotes? It denotes the state of vascular endothelium. So if vasculitis is there, it can be prolonged. But will it be prolonged in Henoch-Schönlein purpura? Unlikely, because HSP is a localized vasculitis in your lower limb. So if you are testing bleeding time at some other place, we usually test in the fingertip, right? So it will not be prolonged. Bleeding time denotes, one is vascular endothelium integrity, second is the number of platelet, third is the functional platelet, and fourth is the presence or the functional integrity of von Willebrand factor. So what is clot retraction? It is the consolidation and tightening of the clot, pulling of contractile elements by the platelet. Depends on, again, the number of platelet and the functional integrity. Now a few terminologies. Decreased number of platelet we call thrombocytopenia. Decreased functional platelet we call thrombasthenia. Pseudo thrombocytopenia occurs when you collect blood for investigation in EDTA bottle. EDTA bottle is a bottle with a purple cap. So that will appear in smear as many clumps of platelet, but platelet count is low. So that itself should kindle suspicion, because platelet clumps means the number is sufficient. Otherwise, clumping will not occur in peripheral smear. So when clumping is there and the count is low, that means clumping is induced by something rather than actual thrombocytopenia. Because in thrombocytopenia, you cannot have clumps of platelets. Now, what are the causes of thrombocytopenia? Thrombocytopenia can be due to underproduction, for example, aplastic anemia, over destruction, for example, in ITP, immune destruction, DIC, it gets used up by in disseminated intravascular coagulation. In thrombotic thrombocytopenic purpura, also there is thrombosis within our vessels, and hence the platelets are getting used up. And the acronym of ITP used to be idiopathic thrombocytopenia, but now it is immune thrombocytopenia, because we are now sure that it is due to an immune mechanism. Now, the third reason for thrombocytopenia is the splenic sequestration or hypersplenism. Splenic sequestration, what does it mean? Even normally, these platelets actually hide within the spleen. So, about 1/3 of total circulating platelet, they simply hide in the spleen and do not come to the circulation. So even in a normal person, if you do splenectomy, the count will rise, because the platelet cannot now hide in the spleen. So suppose you do splenectomy in a thrombocytopenic patient, again the count will increase. So the increase in count is partly due to avoidance of sequestration in the spleen, and partly, for example, in ITP, partly it is due to decreased destruction of platelet due to immune mechanisms, that is engulfing by the macrophages. Inflammatory mediators increase thrombopoietin production in liver and kidney, where they are actually produced normally, and thus there is thrombocytosis in inflammation. Typical example is Kawasaki disease. Thrombocytosis can also occur in severe infections, which causes significant inflammation. So actually, thrombocytosis is a effect of inflammation. Inflammation can be due to malignancy. Inflammation can be due to certain infections. So the thrombocytosis is possible in infection and inflammation. Now, just clarification on the terminology. We said about thrombocytopenic purpura. There is no hard and fast rule regarding the size, but generally peteke we call when it is 1 or 2 millimeter in size. Purpura when it is up to 1 centimeter in size. Ecchymosis when it appear like a bruise, so above 1 centimeter. So there is no hard and fast rule like it should be 1 centimeter and all, but this is the usually accepted definition. And purpura, whether it is vascular or thrombocytopenic, both are not blanchable because it is actually bleed. So if it is blanchable, it is more likely to be some insect bite or things of that sort. Now, platelet, what are the tests for platelet? One is the platelet count. Second is the bleeding time. Third is the platelet morphology in smear. Because if there is thrombocytopenia, more and more immature platelets are recruited into the circulation, which are actually larger than the mature platelets. So you are likely to see large platelets. And also the peripheral smear can tell us whether there is clumps or not, because if there is clump, it possibly means count is adequate. Then platelet function assay that we'll come to in a separate slide. APTT and PT are not indicated, but if it is done, it will be normal because prothrombin time assess the extrinsic pathway and APTT the intrinsic pathway of coagulation. Bleeding time, as I said earlier, is a very crude test, basically because standard size is not defined, but we generally take it as 2.5 millimeter depth and 1 millimeter or 1.5 millimeter wide lancet for the prick. But even then, the prick need not go on to this 2.5 millimeter depth and all. So it is a very non-standardized test. Normally is about 2 to 6 minutes. So you go on blotting the blood that is coming with filter paper. So in about 2 to 6 minutes, it must stop now. Prolonged bleeding time that is bleeding time prolongation means it's a defect in primary hemostasis. So the congenital causes are adhesion defect. It can be either von Willebrand disease or platelet adhesion site GP1B defect, that is Bernard-Soulier syndrome, where the platelets are actually missing the GP1B receptor. Prolonged bleeding time congenital, one can be adhesion defect, the other can be aggregation defect, where the receptor GP2B3A is the one that is involved, and the congenital disease due to that is called Lanzmann's thrombasthenia. The third is the platelet secretion or the platelet granule defect. So the so-called gray platelet syndrome, that is a large platelet, but there is absence of alpha granules. Because of its absence, only the dense granules are present and the platelet appears gray in smear. I have not seen it myself, but that is what is described. Deficiencies of dense granule also is described, but that is still rarer. Prolonged bleeding time, acquired causes. Acquired thrombocytopenia can be autoimmune or immune mediated, where it can be primary, that is ITP, because we do not know exactly what is causing it, or secondary to known causes, for example, SLE, APLA syndrome, or HIV, or hepatitis C, etc. Nutritional, for example, B12 deficiency can cause even pancytopenia, so naturally thrombocyte also can be low. And drug induced, for example, you are on chemotherapy or you are on, say, for example, aspirin, then there will be functional defect of platelet. Now, platelet function analyzer or platelet function assay, I said we will discuss in a separate slide, and this is it. whole blood is taken, and what we use is a cartridge, that is a membrane, coated membrane, because collagen is required to initiate the coagulation. And this membrane has got minute holes through which platelet can go. But once the platelet aggregates, then it cannot go. So when the platelet aggregates properly, then the platelet cannot go through these holes, minute holes. That is called a closure time. So closure time is increased when there is thrombocytopenia, because when thrombocytopenia is there, it takes a longer time for platelet plug to form and block its holes. Usually, two types of cartridge are used: collagen with epinephrine or collagen with ADP. Aspirin inhibits cyclooxygenase 1, that is COX-1, thus blocking thromboxane production within the platelet. Clopidogrel also is an antiplatelet drug, but it acts in a different mechanism, binds to P2Y12 receptor of the platelet, thus inhibiting ADP-mediated platelet activation or aggregation. In our PFA 100 test, COX inhibitors, that is aspirin and NSAIDs, prolong closure time with epinephrine and collagen cartridge, whereas not with collagen with ADP cartridge. Collagen with ADP cartridge, it will be prolonged in clopidogrel treatment, because as you see in this slide, in clopidogrel actually binds to a different receptor, that is P2Y12, and inhibits ADP-mediated platelet activation. Light transmission aggregometry is a slightly more complicated thing. So just imagine that platelets are uniformly distributed in a sample, and you allow a light to pass through. Because it is uniformly distributed, it's sort of cloud, something like a cloudiness. When the platelets are aggregating or sticking to beads, in the test there are beads that are used to make the platelet aggregate. So once that happens, there are aggregates of platelets here and there and here and there. So rest of the area is clean, no platelet. So light passes through. So that is how we look at the result, whether light is passing more after the platelets are made to aggregate. The other tests available would be von Willebrand assay and clot retraction studies. Clot retraction study again is not a very standardized study, but we used to do it in bedside. For example, blood has got about 45% or maybe 50% RBCs. So if you assume that the clot completely retracts and exudes all the liquid part, then the volume of the blood, suppose you have taken 5 ml of blood, suppose the size of the clot is about 2.5 ml, or the volume of liquid part is 2.5 ml, that means almost the volume has reduced to almost 50% of the original. So we can possibly say that the clot is retracted fully, but it is again not a standardized test. So that's all about platelets in hemostasis, especially primary hemostasis. Remaining parts like secondary hemostasis, von Willebrand, etc., we will discuss in separate classes. Thank you for watching.